can I have a, okay. Okay, now I have to gather myself back together.
You got a lot of Zoom meetings.
David, can I have a report of the action taken in closed session, please?
Certainly. The board considered 4 items in closed session this evening. The first 2 items, there was no reportable action. Those were both under Health and Safety Code 32155 related to quality reports. The third item was the approval of the closed session minutes from April 22nd. That item was approved on a 5-0 vote. And finally, medical staff credentialing was considered under Health and Safety Code 32155, and the recommended credentialing decisions were approved on a 5-0 vote as well.
Thank you so much. Thank you again. Are there any deletions or corrections to the posted agenda? Okay, hearing none. And Martina, none came in written?
We did not receive any written comment.
Okay, then we'll move on to item 10, and that's input from our audience. And this is on anything that is not already on the agenda. And if anybody is there to speak, you have 3 minutes, and you can either do it by phone or, Martina, have you gotten anything in writing?
I have not.
Okay. Well, seeing nobody raising their hand, we'll move on to item number 11, input from our Employees Association. Do we have anybody from the Employees Association that would like to speak? Hearing none. And Martina, did we get anything in writing from the association?
We did not.
Okay, thank you. Having no input, we'll move on to 12, Safety First. And we're very fortunate today to have Dr. Gail Pritchard, who's part of our behavioral health services. So Dr. Pritchard.
Can you hear me?
Yes. We can, and welcome.
So we have some slides, but it's not that essential that they be put up. I think Martina has them. So the first slide is really a description of what is a safety plan. I have the slides with me, so I'll read that. A safety plan is a document that supports and guides someone when they are experiencing thoughts of suicide to help them avoid a state of intense suicidal crisis. It's a very straightforward tool, and we'll get into the details in a couple more slides. Slide 2, why is safety planning essential? Safety planning in the primary care setting can reduce suicide risk by 50%. We have something you can click through for a nice presentation that NPR did. And there's a lot of data that comes out of the VA on this as well. Safety plans promote relevant protective factors, including increasing use of coping strategies, social support, and help seeking. Patient safety plan templates include, and this is what the primary care provider or anyone in the health system can elucidate and write down with the patient: warning signs. What are their initial coping strategies? Who are the people and social settings that can provide distraction for them? Who are the people whom the patient can ask for help? And how do they create a safe environment, which has to do with firearms, etc. And that's in the next slide. These are things, really, when you see this, it's a one-page thing, or in Epic, it's a simple document, and you literally put in the names of the people and their contact phone numbers. And so making the environment safe is our next slide. This has to do with medications, the most common method of suicide attempt. And so you encourage the patient, and you have an accountability system with them to dispose of meds that are not in use, keep small quantities on hand, and work with a family member or roommate to lock up and get out of the home or out of their reach other medications that have high risk potential. And firearms is the most common method of completed suicide, sadly, in our country. And we work with patients to make sure those firearms are out of reach. as you can see, the list includes putting them in a locked gun safe and giving the key to someone else, storing ammunition separately, giving the key to someone else, etc. And so then we go to when to complete a safety plan. And it is suitable for all risk levels, mild, moderate, and severe, in terms of clinical presentation or symptoms. Examples include a patient who has a history or active suicidal ideation, a history of suicide attempts, substance use disorders, depression, unstable mood and anxiety disorders, history of trauma puts them at higher risk, chronic pain, and other acute psychosocial stressors. So you can see these are common sort of comorbidities or psychosocial issues that present in a primary care setting. Oh, sorry about that. How do providers access safety plans? The safety plan tool is accessible in Epic for all providers. It's under the FYI tab. You create a new flag, you choose at risk, and that can be pasted into the discharge plan so the patient leaves with this paper copy. And we're working to standardize what safety plan template will we use throughout the health system. And then we will also provide support and training for our providers throughout the health system. So it's an easy tool to use. And then why is it a value to our community? Quantitative findings, mostly through the VA, but also there are some studies in the East with big health systems, demonstrate decreases in depression and hopelessness, reduction in hospitalizations for psychiatric hospitalizations, and improvements in treatment attendance, and that's across all primary care and specialty services. And it's an important tool that reduces healthcare utilization and overall cost. So that's our speedy presentation. We're really excited to roll this out throughout the healthcare system. And it's going to be easy peasy.
Well, hopefully it'll be effective as well as easy
And effective
peasy.
as well.
Yeah.
So
We're not going to let you go so fast, Dr. Pritchard.
sure. Oh, that's fine.
Do you have any questions for Dr. Pritchard regarding her presentation on safety? It certainly was poignant at this time with some of the gun violence and the suicides as a result of that. So I think it's really important that we are all listening to what you have and being mindful of the people around us and what might look like something that we might want to say something about.
Yeah.
Gail, I have a self-serving question. Is this going to be implemented for emergency medicine patients and especially the ones that are low enough level that we discharge home? Is that
absolutely? Absolutely. And then discharging them with a safety plan and also follow up with behavioral health. Or behavioral health intensivists will follow up, track them, and give them the support and for next steps. But absolutely out of the emergency room. It's an incredibly effective tool, and it's really straightforward. And we've had successes in the patients we've shared here with primary care and with you in the ED, where a safety plan made all the difference, They created the safety plan on like a Monday, and on Wednesday it saved their life. So we're true believers. Yeah.
That sounds great. Thanks.
Yeah. Yeah.
Dr. Pritchard, how about in the offices? Are they screening as well? And are they using your template that you're talking about?
Well, we have not rolled this out yet, so that so we've got to get it standardized in Epic. It's just a matter of days. It's not like this is a big mountain to climb on the back end. And then on the front end, it's easy to implement. The one factor that can be a bit of an obstacle is the time. So we need to work with our primary care clinics to see, gosh, should this need emerge and they can't be followed up by behavioral health that very day. If one of our behavioral health intensivists can't come into that primary care setting and do this, who in the primary care might have 30, 60, 90 minutes to really go through the template with a patient so that it's thorough and meaningful. and kind of mentally rehearsed by the patient so that it can become an automatic step if their suicidality increases. So that has to do with allocation of staff resources and who has that time if we can't be the ones who jump in gear and get over to that office right on the spot. It's not like it's complicated, but it goes through time. Yeah, time.
So Dr. Pritchard, this is Art. So aren't you relying on patients being honest about how they feel in most cases? Or are these people that come into the hospital because they've demonstrated already that they have an issue?
No, it's a good question. Most people who attempt suicide will have seen a primary care provider in the prior 3 weeks, including those who complete suicide, something like 85%. And so in most cases, they're relieved and appreciate being asked the questions and being kind of put through this, because then they're not standing alone with that distress, even though there isn't an immediate solution right then. They're not alone with it. And that in of itself can make a big difference. So it's mostly, and so you're right. I mean, people who are going to die by suicide may absolutely choose to withhold the level of their distress, not fully participate with, honesty in a safety planning process. That's absolutely true. And then there's no crystal ball, sadly. And in psychiatry and behavioral health, we know that clinically, we cannot truly predict violence against self or others. All we can do is try to do our best to mitigate and prevent that outcome. So, good question.
Thank you.
Dr. Pritchard, Dale Chamberlain here. Has the incidence of COVID and all the difficulties that come along with it increased the incidence of suicide?
Well, it's true in our community. I'm not the one sitting on that data in terms of comparison for our community up here in North Tahoe, pre and post COVID across different ages and demographics. But nationally and internationally, it's absolutely, especially up tenfold by, overdose and those who are both depressed, anxious, and substance abusing. So that's the number that's touted across communities. It's really alarming. With the isolation of COVID, normal strategies and safety networks have been absent in people's lives, and the structure and routine that has people, distracted by work or other commitments outside their own lives that, were disrupted. So it's very tragic. And additional things will be coming downstream. We see in our teens, this alarming rise in anxiety and depression in our preteens and teens across the country, and again across different communities. Of course, all the researchers and the universities and academics are, kind of pondering and brainstorming, but really putting out a lot of pilot studies that have us understand that neurodevelopment is, really in a heightened state with all kinds of neuroplasticity and pruning and all these processes taking place during teen years that depend on social interaction, depend on eye contact and human touch and smell and pheromones. And the eyes are the seat of empathy. And so when you can look into another's eyes, there's all these neurobiologic changes that take place that are the basis of the positive impact of empathy and social connection. And that's been absent with these kids at home. And so that's it's just one thing to comment on. I could go on and on about that, but that's too much. Sorry. Yeah.
Any other questions for Dr. Pritchard? Any from our audience? Well, thank you again, Dr. Pritchard, for your comments, and we look forward to hearing more about the plan as it's rolled out and EPIC having your template in it. but certainly a situation that's very sad, that's growing in our community as well as across the nation. So
Yeah, yeah.
good things for behavioral health being here. Thank you again.
Thanks for all the support. Thank you.
Thank you.
Bye-bye.
Bye-bye.
Item 13 is our acknowledgement of the Employee of the Month for May. And I think our Chief Human Resource Officer is here, Alex McClellan.
Oh, yes. I'm super honored today to announce that Wendy Lenz is our May Employee of the Month. And Wendy's an amazing person. If you've ever met her, she just shines a brightness in your with positivity. She's amazing. Here are a few things her colleagues say about her. Wendy's been employed with the health system since 2017. And this is what they say. It's hard to imagine an employee who embodies the values of our health system more than Wendy. Every day she goes above and beyond to support not only her team members, but employees throughout the organization. She always strives to do the right thing, and no job is too big or too small for her to tackle. She is a bright light in everyone's day, and she's an integral part of the foundation's success. Another colleague said, on top of her great work in the foundation, she's also a values advocate and an amazing peer supporter. I can't say enough good things about her and how she lives our values in everything she does. She is a great team member and an amazing person. So give it up for Wendy Lenz.
Is Wendy here?
She's truly awesome.
Is she on?
I was looking and I don't see her, but she did accept it. So I don't know if it's one of the
Okay.
phone numbers on the call.
Okay. Well, anyways, congratulations to Wendy and to all of the nominees for Employee of the Month.
Chair Wong, may I add to this? Just
Yes, you may.
a few years ago, when there was a competition for the centerpieces at the dinner, I began to panic, not being the most creative individual in the world that way. Wendy Lenz jumped in and did a wonderful job 2 years in a row and did centerpieces way out of her scope. And she did it on her own time. And so I just wanted to share that with you and thank her for that because I was panicking.
And I think she does that all the time because I understand that she's one of the individuals who wraps all those gifts that we give at Christmas time to our employee families and our senior center. So thank you again, Wendy. And then we'll move on to the medical staff executive committee report, and that would be Dr. Lane.
Thank you. So Dorothy, do you have an agenda you can put up?
Martina, am I able to share?
You're all set.
Okay, thank you.
So we have updated our late career provider policy. Just as a background, several years ago, we tried to come up with a policy to evaluate our late career providers, those practicing beyond age 70, to make sure that we're not doing the same thing that occurs with DMV, that someone's driving and shouldn't have been and should have stopped 5 years before. So we had previously been sending them to what was called the PAPA program down at UCSD. It was uniformly panned by the people who went. They didn't like it. They didn't think it was objective or fair or adequately assessed what needed to be assessed. We have now we have signed a new contract with a neurologist, Dr. Crum, in Reno. So it's not a multi-day thing. It's a half a day. We've sent one physician through it. And while he didn't say he enjoyed it, he thought it was much improved from our previous one. And the idea of this is to do a physical exam, a cognitive screening exam, psychological screening, and depending on what type of work you do. So if you do procedures, there is a dexterity test. And it's really just to confirm that those people who hit age 70 are still competent and doing a great job. We've updated our policy, and I guess we've done it. The policy says that we can send people to any course that MEC approves. And now we've also included all of our allied health professionals, staff members. So pretty much anyone who's providing any kind of clinical care is going to be evaluated once they hit age 70. This was included in your packet. The changes we made were relatively minor, and it was more to make sure that we weren't locked into the San Diego program, and we can change programs if we wish. Any questions on that?
Dr. Lane, do you have any coming up this year that will be going through the program?
We do. We have several, at least that I know of. I don't know the total. Dorothy, do you know the total?
I think it's about 6 or 7. And the program was on hold just because of COVID as well. So, we're reinstituting the program now that, some of these bans have been lifted. And so I believe there's about 7 total though.
So we'll have a better idea of how they're accepting it because you'll have more people going through it.
Right. And while I don't expect it to be a popular, fun thing, what I'm hoping that people will say is, yeah, that was a fair assessment to make sure that I'm performing at a level that I should be. And we've also written this in a way that says we're trying to protect our patients, but we're also trying to protect the providers so that they're really functioning at the level that they expect to be functioning at.
Dr. Lane, and of course, they'll find it more acceptable if they pass. If they don't pass, I assume they'll object. But is there a national effort to develop something that's universal, that is more objective and acceptable?
Dale, the short answer is no, that people recognize this is important. It's like many of the policies that Tahoe Forest wants to develop that I'm a part of. I'm always saying, well, why don't, let's look at 5 other similar sized hospitals or even the mega hospitals, and we can re-edit what they have. There's not much available on this. People recognize it's a concern. A lot of medical staffs have thrown up big roadblocks. They don't want to be evaluated. They don't want to be checked. So the answer is no.
Okay.
And let's see. Next is trauma program resolution. We just have a resolution that we wholeheartedly support our trauma program. I'm not sure it's already been reported to you, but we now have a date for our, the American College of Surgeons is coming in September to do our evaluation. This will be a virtual one, but it'll be a 2-day evaluation. We already have the dates in the September 26th and 7th, somewhere in there in a few days from there. And we have every expectation we will be approved as a level 3 trauma center.
So Dr. Lane, why is it important to have a resolution that's signed by the board?
I don't know the answer to that.
It is a regulatory requirement for the program.
Okay,
Sorry,
that's what I was wondering. Because we've been certainly talking about this and encouraging it and doing as much as we can to get designated. So I wondered why we needed a resolution, but that answers that question.
It seems odd we've been putting massive amounts of manpower and now we're saying like, yeah, that's a good idea. Let's go for it.
Okay.
We updated privileges form. Actually, we have now an audiology privilege form and a PA-NP privilege form. And the audiology one is for all the audiology folks, what they need to have to be able to apply for privileges with us. The NPPA, there's some general things, but it also gets very specific depending on people's area of specialty. So we don't think all NPs and PAs need the general everything, and we're letting them consolidate down to those they do. And so we have updated all of their privilege forms. We have come up with an RNFA, which is Registered Nurse First Assist. So it's a registered nurse who's taken additional classes to be a first assist in the OR. We now have privilege forms for them on what they need to be able to do, the experience they need, and the references and the amount of malpractice and those things that they need to be able to work as an RNFA. And The last one is we're adding RNFAs to the hospital staff. We've had to make a few changes to our Idpc committee, which is Interdisciplinary Practice Committee. And that really includes all of our ancillary services, PAs, NPs, nurses, anyone who has policy and procedure forms. And the committee, we've had to change them. There's a Title 22 that dictates who needs to be on the committee. So we now have to have at least 2 physicians and 2 nurses, and then representatives from the other aspects or the other specialties. And we're updating that and making sure we're in compliance.
Dr. Lane, on the RNFA, it says new privileges, but haven't we always had RNFAs?
The privilege form is new. So now we have, now we've delineated clearly what the privileges are. So it's,
Okay.
it hasn't,
So Alice, when we had them, it was probably 6 or 7 years ago.
Uh-huh.
And when we stopped using them, there was no reason to have the privilege form. So it's sunset and we're reinstituting the.
Okay. And since we're on the RNFA, what is the difference between the APP first assist, other than their credential, and the RN? Can they do the same procedures in surgery? Or what's the difference between them beside their credentials? One is just an RN and one is an advanced provider.
Dorothy, correct me if I'm wrong, but my recollection is there are certain independent things that the APPs can do that the RNFA can't do, like finish closure when the surgeon leaves the room versus the surgeon staying in the room and stuff like that. I'm not 100%, but that was my understanding.
Okay.
and for everyone else, APP refers to any advanced provider, and it really encompasses nurse practitioner and PA.
Right, okay. But I was just thinking more of the skill set they would have to have in order to be in surgery. But I think Dr. Cole's answered the question with if the physician leaves, that the APP can continue on with whatever the procedure is.
Dorothy, is there anything else, or is that our list?
That was our list for our consent agenda for approval.
So does anyone on the board have any questions for me before I check out?
It doesn't look like the board. How about the audience? Is there any questions from anybody in the audience? Okay, since I hear none, can I have a motion to approve the medical staff executive committee consent agenda?
This is Art. I move to accept the consent agenda.
Dale, I'll second.
Okay, it's been moved by Director King, seconded by Director Shamlin, that we approve the presentation of the consent agenda. Please take a poll, Martina.
Director McGeary,
Aye.
Director Shamblin,
Aye.
Director King,
Aye.
Director Brown,
Aye.
Director Wong.
Aye. So the consent agenda from the medical staff has been approved as presented. And thank you again, Dr. Lane. And you too, Dorothy.
Thank you both.
Thank
Thank
you.
you all.
Oh, thank you.
And one, before I leave, and I mentioned this to Alice at our last MEC meeting, all of us at MEC, and especially myself, I really appreciate the collaborative role that MEC and med staff have with the Tahoe Forest Board, and the working together in a collaborative manner versus a combative manner, which was the way it was maybe 5 or 10 years ago. But it just makes things run very smooth, and it all seems that we're all working hard for the same goal, which is, the betterment of our healthcare system and treatment of our patients. So I very much appreciate that, and our med staff really appreciates it. So thank you all very much for the hard work you're doing and the collaborative manner in which it's done.
And we feel the same way about
Yeah,
the medical staff
thank
as
you.
well, Dr. Lane. Thank you again.
All right.
Okay, moving on to item 15, it's our consent calendar. And these are pretty much reports or minutes. They're usually non-controversial, but certainly any of our board members can pull an item if they wish, or anybody from our audience can pull an item. Anybody interested in pulling anything from our consent calendar? Okay, hearing none, can I have a motion to approve the calendar as presented?
I'll move to approve the consent calendar. Michael?
This is Mary, I'll second.
Okay, so it's been moved by Director McGarry and seconded by Director Brown to accept the consent calendar as presented.
Director
Martina?
McGarry,
All right.
Director Shamblin,
Aye.
Director King,
Aye.
Director Brown,
Aye.
Director Wong.
Aye. So it has been, the calendar has been approved as presented. Item 16, items for board discussions. We have Scott Baker, who is going to talk to us some more about what's happening with the clinics and rural health update.
Yes, thank you, Chairman. Good evening, everybody. Just wanted to provide an annual update as we promised to do on our RHC development plan. I was shocked to remember that it's been over a year since I gave that presentation at one of the last in-person board meetings in Eskridge. So it's been a year. Our RHC program continues to grow. We have 3 current RHCs. Our pediatric RHC, which is going on almost 2 years now. I am cardiology, which is about a year, and a second floor of the Incline Village Hospital, the health clinic there, a little over 6 months, 8 months as an RHC. We have applied for and have a completed application packet for the second floor of the cancer center. We're just waiting on the on-site review from the compliance team, which acts on behalf of CMS to approve the RHCs. We expect that anytime. Obviously, with COVID ongoing, everything's a little bit delayed. We don't know if that's going to be in person or a virtual inspection as it was with Incline last year, but we're waiting to hear on the second floor of the cancer center. As expected, we're seeing a lot of traffic through the RHC billing. About 22% of our total billings in those clinics are under the Medicaid portion of the RHC guidelines, and about 25% are under the enhanced reimbursements for the Medicare guidelines. So about half of our patients through those clinics are being billed through the RHC program. So it is an important strategic objective for us. And if Crystal's still there, I'll ask her to maybe update us on the rate setting for the Incline, which is an outstanding item for that application.
So we continue to work with the state of Nevada to try to get our rate set in place. At this point, we're probably still about 6 weeks out. We have been working with them on a waiver because since Incline was certified a while ago, the claims are starting to get stale dated. But with the waiver, they will accept our claims from the time of certification, so we won't miss any reimbursement on that. But it has been a very slow process, even with the state of Nevada, just like it had been with the state of California, unfortunately.
Yeah, so if you remember, once we get the certification as an RHC, from that day forward, we can start to bill as an RHC, but we hold those claims until the rate is set through this process. So we're holding an awful lot of claims and a lot of money until that rate setting process is complete for the Incline Village RHC. So that's the latest, but if you have any questions, I'm happy to entertain them.
So when you say a lot of billing is being held, are we going to see a big jump in gross billing at some point when all this is approved? And are you talking 5%?
So it's not about the billing, Dale. Once the patient is seen, they sit on the accounts receivable. So once we can send those claims out for reimbursement, then we can get those off the accounts receivable.
So they're just not collectible until it's done.
Right.
Yep, they're just sitting there for now.
Gotcha. Okay.
This is Art. I have a question. Do we have any idea what the bottom line financial impact is to the hospital on an annual basis of our RHCs? You know, if we
I'll let
didn't have them
Crystal-
versus having them?
Yeah.
So that's a little challenging at the moment. We soon shall be able to give you that number. Because it's taken so long with rate setting and with the kind of moving some providers around and getting the GL aligned with where everyone's located, and then filing the cost reports for the true up of the actual rates takes a little bit of time, but we should be able to give that to the board soon, kind of final analysis, so to speak, of how well the rural health clinics are doing. I will tell you, the change in reimbursement just from Medi-Cal alone, which is, you know, the 22% that Scott talked about, we're really talking about at least 4 to 5 times, actually more than that, in additional reimbursement that we would normally get from the Medi-Cal program. So it's pretty significant, the enhancement we get, because it's all really cost-based reimbursement in a clinic setting, just like we have in the hospital.
Yeah. Okay, thank you.
Scott, as far as physicians working in the rural health clinic, do they have to be approved or they have to be certified, or they can move in and out as we need them?
Yep. There are certain provider credentials that are allowed in an RHC and some that are not. But outside of that, it's really about the RHC certification for the clinic, not each individual provider. The providers, by and large, it's completely invisible to them. They don't know.
Okay.
Well, the only thing I would add there is the mix of the type of provider does matter.
Yeah.
So the percentage of primary care versus specialty care does absolutely matter.
And we have to have a certain percentage of the APP visits and all that, but outside of that, yeah.
Any questions from our audience for Scott? Okay, I guess you're off the mic now.
Thank
We
you.
look forward to hearing about the 4th clinic when you get credentialed on that one.
Will
So
do.
thank you again for your time.
Sure.
So Ted Owens, our legislative guru, has got 16.2, 2020 legislative update.
Good evening, Chair Wong and directors. I will move as quickly as I can, and I will finish, and I'm saying this for Crystal because I will need her on this one probably, on AB 650. I'm going to say that for the end. I'm going to give you a little bit of rundown of some pieces of legislation that we are paying attention to in Nevada, California, and at the federal level. There are many more than just the ones I will cover, but these are ones that raise kind of to the top. Right now, we are paying close attention to, in California, Assembly Bill 1130, which is a Wood bill. Assembly Member Wood is a dentist, a provider. He's been very helpful to us in the past. However, he is carrying 2 bills that are a little disturbing. One creates an Office of Healthcare Affordability. This is in alignment with Newsom goals in California, and Wood has taken up that charge. This would establish and enforce healthcare cost targets, and it would establish a 9-member healthcare affordability advisory board that would be comprised of by the governor. So it would be a political board. They would be analyzing health charges and expenses and have an influence over rates is the general goal. This was a part of a bill that you heard of last year that was carried by Harry's good friend, Senator Monning from Monterey. He has been termed out, and that bill was killed last year. And it also had a component to it that is also a Wood bill, which is Assembly Bill 1132. And what this bill would do is it would require that all health facilities, sales, leases, transfers, and mergers over 5 million must be approved by the Attorney General's office. So it's more top-down control. So we're keeping an eye on both of these bills. They were packaged as one last year. We were able to defeat it, but now it's 2, and we're going to have to play the game that way. We are also paying close attention to a Cortese bill, Senate Bill 213, which would create a rebuttable presumptions that infectious disease, COVID-19, cancer, musculoskeletal injury, PTSD, or respiratory diseases or occupational injuries for direct patient care workers. This is a workers' compensation matter. The interesting thing that is about this bill is it does have timelines for the filing of claims, but the filing period for COVID-related claims is 10 years. That is a long tail to have on anything having to do with workers' compensation. We're paying attention to this. It would have potentially dramatic impacts on our workers' comp rates that we pay. There is some good news, though. Jim Wood was good to, yes?
Excuse me, Ted, as you go through these, could you tell us which direction the winds are blowing on these and how strong
Sure.
that wind is?
Absolutely. So the Wood bills, he is very prominent in the assembly, so his bills have legs and they are moving through the committee process. The opportunity probably to stop those will be in the Senate. But it's moving through the committee process. Both of them are moving through the committee process right now. And so is the Cortese bill. That's why we're watching them. So we're in the first year of a 2-year session. We've got the May budget revise done. I chose not to talk about that tonight because we'll be here for a long time. So we now know what's firmed up as legislation, what looks like it's going to be continuing forward. And these are such bills. Does that answer your question, Director Brown?
Yes.
Okay.
Yeah, thank you.
We do have now where Assembly Member Wood has kind of gone against the industry this year a little bit, which is a change for him. Assembly Member Aguiar Curry, who has been a tough customer for us in the past session, is actually doing something that we like. It's a telehealth bill, AB 32, and we have hope that this might proceed through the rest of the process unscathed. This bill will extend the telehealth flexibilities that were put in place during COVID, which have been vital to ensuring the health provision to the public, especially in rural areas. It would require health plans and insurers to reimburse for audio, video, audio only, and other virtual communication on the same basis and to the same extent as the plan insurer is responsible for reimbursement for the same service in an in-person visit. So a bold step, but I think it'll be interesting to follow this because it may be beneficial. The challenge for telehealth has been in the past that the reimbursement was so low that it's, can we afford to do it? This takes a step in the right direction in leveling the reimbursement levels. So we will keep an eye on that because I'll be telling Crystal how that one's moving along.
And that was Ted? That was
AB 32.
AB 32.
Assembly Bill 32. Aguiar Curry, Assembly Member Aguiar Curry. In Nevada, I know I was going over this with Alex of his staff today, and I don't know if you'll get it, but it's Assembly Bill 420. And I had to learn what 420 meant around my daughter and her friends. It kind of refers, you know what I mean. So I find it amusing that the public option bill in Nevada is called AB 420. This bill would force insurance companies participating in the state's Medicaid program to offer a public option plan that would be designed to lower insurance premiums across the board by 15%. That is the goal. And it would have, I think they're shooting for premiums that are 5% cheaper than the second lowest silver plan offered in their version of ACA in Nevada. And it's like other bills in Nevada, it's not really well thought out right now. There is concern that it could cause insurance providers instability, medical providers to avoid the Medicaid programs completely. So it might have a result of lower access to care. That is a concern. However, there is a amendment that is on the floor right now, which will be heard tomorrow, that we do support. And that amendment would require an actuarial analysis be done to determine the impact on the uninsured and the underinsured populations in Nevada, but also the state's insurance markets and healthcare providers. I think that's a real where they move forward with approving this bill. There's too many questions. The process for a while. Any questions on AB 420? If not, I will, by the way, if it does pass, it would not take effect until 2026. So it would be in workshop for a number of years for its full fleshed out development. We're paying attention to Assembly Bill 348, which is, it was passed last year. This is the Patient Protection Commission that would operate out of the governor's office. The Gorlow bill would change the composition that was originally passed in what was AB 478. And it dilutes the commission because it will include members from outside of the healthcare industry. And we don't believe that to be a very good idea. So we'd prefer it to stay the way that it was passed and last year's law was intended to be put forth. So we'll just keep an eye on that one as we move on. I've been working with Alex on a Senate Bill 470, which is cultural competency in Nevada. This bill passed last year and it upped our cultural competency requirements. And again, this is a bill that they didn't really flesh out the how do we get there part. So Alex and other hospitals and in Nevada have been struggling with who is certified to train, where do we get the training, how do we comply with this requirement? The state does know that they have this problem. They're not going to penalize anyone this year. It's already in effect. Only 2 hospitals are in compliance right now. And I'll be working more with Alex and the NHA to get to the bottom of how we can accomplish the requirement through certified training, and hopefully we get certified to train in-house on our own. I don't know if Alex, if you want to add anything, did I miss something on that one?
No, I think you covered it well, Ted. Thanks.
Okay, thank you, sir. And we have on the federal level, a little uplifting is for Crystal. We have HR 3203, which is being carried by Congresswoman Doris Matsui out of Sacramento. And this bill would enable hospitals that are participating for or in the drug discount program under Section 340B. That's the reduced pricing on some outpatient pharmaceuticals, for eligible providers. It would extend it. They're trying to kill the 340B program. If this bill's moving, which is nice, this would extend it and buy us some time. I think ultimately the Fed will do away with 340B, but at least we have somebody fighting for us to buy us some time on it. I don't know if Crystal wants to add anything on that. I know that she pays close attention to it.
I really don't have anything to add other than we need this program to continue on. It's pretty significant for us.
Well, we will. I will keep you informed, all of you, as this moves forward. Then there was something that Alex alerted me to, and this is the signing of Senate Bill number 342 in the Nevada legislature. It was signed by the governor, and Alex told me to look at LinkedIn, so I did. And you can't see this, but that's Governor Sisolak signing the bill, and there's former Governor Sandoval off to the side. And he's now president of UNR. And the statement is from Tony Slonim that says, I appreciate and so pleased the governor signed in this legislation, which is support for integrating the University of Nevada, Reno School of Medicine with Renown Health. So this is enabling legislation that was signed that allows that affiliation and the Board of Regents to act in this manner with UNR and Renown. We should keep our eye on that. But Alex had me research that, and kind of I sense two governors having a conversation in that one. And now for the grand finale. This is the one I think that we are most concerned with at this time, and that is California Assembly Bill 650. And this bill requires specified employers to pay bonuses to specified healthcare workers of up to $10,000 in increments through the year 2022 for work done in 2021. This is a COVID hazard pay bill. It's gone through a lot of iterations. At first, it was only applicable to employees that worked in the hospital setting. Then it expanded to include administrative staff that is non-managerial. So they broadened it. It excluded hospitals or health systems not owned by the state, a municipality, or any political subdivision of the state. However, we're a public subdivision of the state, a political subdivision of the state, but they included hospital districts. So the UCs wouldn't have to do this. The county hospitals wouldn't have to do this, but we would. This is an SEIU supported bill, by the way. So that's what's running this. It would be a payment of $2,500 to each covered healthcare worker that worked full-time, $1,500 to those that worked part-time, and $1,000 per quarter to those that work less than part-time. Changes that have been made. They now include the UCs and the county hospitals to alleviate that disparity. However, that's not really as nice a deal as it might sound, because today when I was in Sacramento, I learned that in the budget appropriation process, they have created a fund with $1 billion from the surplus, the budget surplus, that will go to offset the expenses for the UCs and the county hospitals, but not us. So this is sausage making at its finest. It's estimated to cost the healthcare industry in California $7 billion. It's estimated that it will hit us for $8 million. And I'm sure Crystal has a few words to say. She sent you some information on this I saw last week. The other things that make it a little challenging is if we hire an employee in the last quarter of this year and they stay in our employ into next year, we are the responsible party for paying them the full amount if they work 3/4 of the year somewhere else. It will be very, very hurtful to our sister hospitals to the north, Eastern Plumas, Banner Lassen, Mayor's Memorial. This will be a big unexpected expense. It has very serious legs. It has been moving just fine through the assembly. I expect it to reach headwinds in the Senate, a much smaller body, more deliberative, and beginning to feel the heat from hospitals within their districts, which are much larger. So you have more members that have affected health systems and hospitals by this legislation. I believe that if I were Governor Newsom, I would not want this to land on my desk, because he, of course, has a very good relationship with SEIU, and he's trying to cost control healthcare with the health systems on the other side. It puts him in a pickle. And I would expect that probably what he would likely do would be to not veto it and to not sign it and let it expire for lack of a signature over time. But it's a very concerning bill. There is a language that creates a credit for us to offset any of our COVID costs that we put forth on behalf of our hero healthcare workers during the pandemic, but it is poorly written. It will be difficult to qualify for it unless that's changed. But it's really a hammer to us. It's playing Santa Claus with other people's money, is basically what it is. Understand the intent. Don't take anything away from all those folks that have provided care and service to patients throughout California during COVID. That's not the issue. It's the methodology that is such a big concern. With that, if Crystal wants to add some comment to that, I'd be open for questions. Sorry, I ended with the bad news.
No, Ted, I think you summarized it extremely well. Clearly, it's got a potential significant impact on us. I'm treating it as a probable issue right now, which is why you've seen me be a little more proactive on our financials to start recording some level of liability for fiscal year 21. I'm also incorporating the impact of it because it's going to trail into our fiscal year 22 because it's based on calendar year 21, not our fiscal year 21. So we'll see 4 million in 21 and about 4 million in related to 22 through December 31st of 21. If things change by the time I put the budget before you, we will remove that out. And it's been changing very quickly. I mean, the criteria, the involvement of health systems, I mean, it's like day to day. So it very well could be something different by the time you see the budget package in June. I will definitely confirm from my district hospital leadership forum CFO calls. I know of at least 3 CFOs that are already working on filing for bankruptcy if this 100% goes through. It is like the nail in the coffin for them. So it clearly has a significant impact on us, but they cannot afford the cash outflow in 2022 that will be required, and it's just going to do them in. So yeah, I mean, to Ted's point, it's not to take away from any of the work any of the healthcare workers have done through COVID, but it definitely has huge financial impact on a number of health systems.
Thank you. Ted, this is Art. So when will we know if this passes or doesn't pass? What's the timing on that?
I expect that it will move out of the Senate. It has to. There's a deadline coming up, and then out of the Assembly, excuse me, it'll move to the Senate, and it'll go through that process. All bills that are destined to be signed have a deadline in the fall to get out.
Oh, okay.
And then it would go to the governor. This one, they have to make a go of it right now. They can't allow it to go into the second year of the 2-year session because it'll be stale.
Yeah.
It's moving too far down the road, and that's why they're hitting it hard. So I'll give you periodic updates as it moves through the committee process, when it moves to the Senate, if it goes to conference, and if it goes to the governor's office. But we're going to be very active with Senator Dolly, our senator, and Assemblywoman Dolly. They have the biggest districts. I think Brian has 14 hospitals in his Senate district, almost all of them rural, with the exception of Reading. So he's very, very good at crossing the aisle. And I think he will be very instrumental and part of the team with CHA and ACHD and the other players to try to head this off in the Senate.
So our associations are pretty active in this as well. CHA and ACHD.
Yes, and DHLF is watching this very closely. So yes, they're organized. There's a PR firm that's hired. There's a No on 650 website. I'll get all of that information to you. So money's being spent on fighting this. Director Brown.
Yeah, I'm concerned not only about the passage of this, but also the messaging to our employees with regard to this. I mean, obviously, we are opposed to it the way it's currently written. But how do we message that to our employees? I mean, you referred to this as Santa Claus, and they may be looking for the Christmas tree.
Yeah, I agree. And we're very sensitive to that. So I was paying attention to the phone numbers on the screen here this evening, because we want to be very careful about how we message this. That'll take some work with me, with Paige, with Judy, and others to really be and Alex, to be very careful. There's other things at risk if we are hit with this that we all enjoy. This will take a bite out of potentially even gain sharing. There are inequities in it. So not everybody that works in our family will enjoy this benefit. Some will, some won't. So there are weighted factors, I think, that we have to carefully address as well with our staff as we move forward. $8 million has to come from someplace.
Yeah, I guess I'm just looking for the reassurance that we're doing this very carefully and very thoughtfully.
And that is a very strong concern with the ACHD, the district, with the other district hospitals as well. So there's a lot of conversation on that going on. I think we'll be reliant upon some of the work they've already done on the website that really kind of lays out what the risks are. Certainly for some hospitals, it'll be easy, as Crystal pointed out, they'll just have to declare bankruptcy. So it's, I hear you, Director Brown, and worry about the same strategic thing.
Ted, if the governor vetoes it, the veto could be overridden, could it not?
He could, but I think in the governor's situation, a veto sends a good message to one side, but really will anger another. Okay. Yeah. Letting it die for lack of a signature kind of is a way of saying time out.
Yeah.
And not take a side.
Yeah.
So I would imagine that Dale, he doesn't want that thing to make it to his desk. It's one of those pieces of legislation governors don't like.
Yeah. Yeah.
Especially because his argument, on some of these other bills, creating the Commission on Affordability, he wants to drive healthcare costs down for the public. But when you're talking about a $7 billion hit to healthcare coming out of COVID, he knows that that's going to drive costs up.
Yeah.
So, yeah, it's a squeeze play.
Do we have any other questions for Ted from the audience?
Good summary.
Yeah.
Yep.
Well, we will be looking forward to hearing more about what's going on with that, Ted, as you find out information, but certainly not only worrying about those employed who might take it the wrong way, but if indeed those hospitals declare bankruptcy, that means there'll be a population that will not get health services, which is just as bad as everything else. So again, we want to hear more about it, and we'll just keep our positive thinking that we might let it just sit on the desk of the governor for a while.
Yeah, well, I will gladly do that.
Okay, but you're not going to go anywhere right now because you have another item for us.
That's right.
For board action.
I do. This involves the Placer County LAFCO, Local Agency Formation Commission. And local agency formation commissions generally decide boundaries of cities, boundaries of special districts, spheres of influence, whether you can expand or not. Hospitals, or healthcare districts like us, are a different animal for them. So, so we're treated a little bit differently. They are comprised of 2 county supervisors, 2 members that would come from city councils within that county, 2 members from special districts, and 1 member at large. And it's an important commission. It can have an impact on us. And right now, the special district positions are up for election. The ballot didn't make it out to everybody on time, so there's an extension. And we're just taking care of business and put it on the agenda real quickly. I have a recommendation. We have 5 candidates, 2 of which hail from Eastern Placer County. That would be Fred Eifelt from Olympic Valley Public Services District, and Rick Stevens from the Airport District on this side. I think, having served on LAFCO for 10 years in Nevada County, it's important to have representatives from this end of the county and not have the game get played by everybody in Western County. It's a long shot, but my recommendation would be that we vote, that you vote for the 2 local candidates, Mr. Eifelt and Mr. Stevens. You might ask, why are we in Placer LAFCO when the hospital's in Nevada County? It is because the property tax valuation is greater in our district in Placer County than it is in Nevada, and therefore we are assigned to Placer LAFCO. With that, I'd be happy to answer any questions, or I'll turn it over to the chair.
Do we have any questions about LAFCO or the two gentlemen that are running from Placer?
Eastern Placer.
Eastern Placer.
Eastern Placer. Okay.
Well,
If not, oh, go ahead.
Yeah, I do have a general question. I find it actually difficult to either support a vote or, I mean, Ted, trust your recommendation implicitly, but I have very little information to even support the recommendation. So, wondering how we kind of proceed.
I understand. And not much information, no information comes about the individuals on the ballot. Yep. It's just distributed. And so I do know Fred Eifelt. I do know Rick Stevens. I know that they are passionate for what happens in Eastern Placer County. They have been friends to the health system from time to time. I don't know anything about the other 3 candidates, except they hail from Roseville and Western Placer County. Mm-hmm. So my recommendation is strictly based on, well, I know them, I like them, but more so it's based on the fact that they hail from up here, which is important to me in my role with LAFCO. David, I see.
I'm also familiar with Mr. Eifelt, and I know that he has considerable LAFCO experience because he was involved with the group that attempted to incorporate that area of Placer County, which was a long and bitter battle. And it provided him with quite a bit of experience dealing with LAFCO issues. So that's about all I can add to that.
And my question was really not to push back on your recommendation. Again, trust you implicitly on that. It's more on a process that, to the extent there's no additional information, then that's what we get. But
this is how I've seen all LAFCO special district selections happen.
Yeah.
And it's just like your insurance company when they send you the ballot for the board of trustees or the commission or whatever. You don't know who any of them are, and you go, well, whatever the major vote is, that's what I'll vote for. So.
Oh, a question of procedure. So the board is making this decision? This is a board vote?
This is a board vote, so.
This is not something we're going to get in the mail, and you're telling us.
No.
Okay.
No.
And then, have we done this before?
Yes,
the board
we have
voted?
before.
Okay.
It would require a motion, a second, and action. And then we will seek the chair's signature, and I will forward it to Chris Berry at Placer LAFCO.
Yeah.
So who else votes? I mean, who?
All of the special districts in Eastern Placer County.
In all of Placer County.
Pardon? Or all, that's right, all Placer County. I was starting to think about the school district there because they're not a part of it, but their boundaries are like ours. We're just in a unique position on this one.
So how many special districts are there?
In Placer County?
Yeah, you have a
David,
guess?
you probably know. I wouldn't even guess.
There's got to be quite a few.
Yeah.
Quite a few, okay.
That's a polite way of saying we're probably going to lose on this.
Yeah.
Oh, okay, all right.
Okay, so do I need to make a motion, or someone needs to make a motion to choose our nominees for the Placer LAFCO? Can I have a vote or a nomination of 2 people, please?
There was no public input on
Oh, sorry.
those decisions. Doesn't look like there's anybody.
Well, yeah.
Looks like it's just staff in the meeting.
Okay, I'll move that the board, if I've got this right, nominates Fred Ilfeld and Rick Stevens to be on the Special District LAFCO board. Is that right?
On the representing special districts on the Placer LAFCO board, yeah.
Well, thank you. That's close. That would be my nomination.
Okay. So could I have a second to the nominations?
I'll second that, Dale.
Okay, so it's been moved by Director King, second by Director Shamlin, that the nominees from our hospital district our nominees, our vote is for Fred Illid and Rick Stevens for the LAFCO Placer board.
It's not
Gary?
easy, is it, Alice?
Director Shamblin,
Aye.
Director King,
Aye.
Director Brown,
Yes.
Director Wong.
Aye. Okay, so those will be our 2 nominees, and then if you'll let me know when to come in and sign that form, or if I can sign it electronically.
I think we can do it electronically, be fine. Martina
Okay.
will help me with the technological challenges I would have.
Okay. So anything else about LAFCO? Nope. All right, then we'll move on to, we didn't pull anything from our consent calendar, so now we're on to board committee reports. And from my understanding, we just had a quality committee report since our last meeting. And that would be Michael McGarry.
Yes. Sorry, checking my notes. Let's see, we got an update on the board quality committee. We got an update from the family and patient-centered care. Beta Heart update was really positive, had a 90% survey response, which was incredible. And then we reviewed the IHI framework and identified 4 areas for monitoring and quality improvement. The cost of poor quality was 1, equitable and patient-centered care. And then 2 that are really related, I think, around access, timely and efficient care, and then continuity of care for behavioral health. Were the relevant updates there from the board quality committee.
Thank you, Michael.
And then we did not have a foundation meeting, but I did see an email today with regard to some activity that Director Brown had for a significant donation. Is that true?
That's true. Yeah, I didn't do anything to solicit this. I simply got a phone call from a friend from the Bay Area who is about to make his permanent home over in Lahontan. And he had $100,000 that he had to get rid of in 48 hours. Oh, well.
Oh, wow.
So, yeah, so he was looking at some other possibilities, he and his wife and what have you, but, bless their hearts, they're just moving up here, but have already impacted our community and our health system in such a wonderfully positive way. So,
wow.
Wonderful.
I don't have very many things like that, I can assure you. But,
So you're going to be driving a new car, Mary?
but yeah. It was serendipity, Michael. But yeah, it worked out well.
Fantastic news, and I think many of us wish we had problems like theirs, but to our benefit.
Yeah, I do too.
That's great news.
All right. Any other good news from anybody? Okay, if not, my only good news is that my fingers are crossed for next week, because my understanding from COVID reports that Nevada County will be down to the orange tier. And that's what, if you follow the statistics, that's what it looks like. And then in 2 weeks, we'll hear from the governor, and we may all be seeing each other again in person. So I look forward to that.
Wonderful.
We all do.
Okay.
Are we still thinking July?
I'm sorry, what?
Still thinking possibly July we would be meeting in person?
Well, we'll have to work out all the logistics because of the conference room. And as soon as we have all that in place, then yes, we will be meeting, if that's what the governor, with whatever restrictions he puts in place.
Along with the California Department of Public Health, who manages the health
Yeah.
system, which is a little
Yeah.
different than the public. So we'll have to wait and see what they recommend.
Thanks, Sue, for
Yeah.
clarifying that. Okay. If there's no other closing comments, then this meeting is adjourned.
Thank you.
Thank you, everybody.
Good
Night,
meeting.
everyone.
Thank you.
Good night.
Good night.